はい、4月12日、2017年4月12日、今日は、新聞持って東大に行って、資料がなくて、新聞拾って、飯田橋に行って整理して、ブックオフで買って、新宿に新聞配って池袋で資料を資料を切って分けて配って終わりでした。今12時です。スタートは6時、7時ぐらいでした。7時ぐらいです。ということで、今日も早く帰ってパソコンで情報出そうと思いますけどね。いやー、今日はなかったですね。東大に行ったらみんな捉えてたのか、あれが違ったのか、曜日が違ったのか。この間月曜だったんですけど、今日は晴れてますけど、これ雨濡れてましたね。いや疲れた。特別いいことないんですけどね、もう。じゃあ終わりましょうか。
So this may be very familiar territory. Hopefully you can have some good questions or additions to the commentary. So I wanted to start with just a couple of examples, fairly randomly selected from the New England Journal of Medicine. This is a study, double-blind, placebo-controlled, randomized study of people with traumatic brain injuries in the emergency room, given progesterone to see if it made a difference in their symptoms of recovery. And this was a study that was done without informed consent. It was done in the emergency room. Here's another example of a study looking at children with vesicular, I can't say the word, reflux. And again, it was a double-blind, randomized control study to see if antimicrobials made a difference in terms of reflux. And another study where the participants were pregnant women, and they were randomized to 2 different time points in terms of thyroid screening, and if they screened positive on the tests that were done, they were given levothyroxine. The primary outcome of the study was cognitive ability, or IQ actually, in their children at the age of 3. So all recently done studies, published in the England Journal of Medicine. So I think the interesting question to ask ourselves is, are these studies ethical? And if you think so, or if you're not sure, the question is, how do you make that decision? So just for the people in the room, what do you think makes studies of the nature that I just showed you ethical or not ethical? Any ideas? Informed consent? Okay. So we had CBI patients who couldn't give informed consent, children who legally can't give informed consent. So does that mean 2 of the 3 were not ethical? Not necessarily, right? Okay, risk versus benefit. And we didn't go into the details of those, but we'll talk about that a little bit. Anything else? Yeah? No actual harm? Okay, so that kind of falls into the rubric of risk versus benefit. I think it's really interesting to think about what does make research ethical. And so that's what we're going to talk about. I want to point out a couple of things before we go there, though. What I often think of as the inherent moral tension, or the ethical tension in research, is pretty much captured by this slide. And that is that the goal of research, the goal of clinical research, is to generate knowledge, useful knowledge about human health or illness, ways to prevent, diagnose, or treat diseases. And the goal is not to benefit the individuals who participate in the trial, although sometimes they do benefit. So that sets up this interesting problem ethically, and that is that the people who are asked to participate are actually the means to developing useful information. And therefore, they are at risk of exploitation. And that's really what a lot of the ethics of clinical research is sort of aimed at attending to. We know that sometimes people think of clinical research like this. You know, that people who participate in research are human guinea pigs, that they are susceptible to exploitation and sometimes are exploited. The lay perception of research often is this understanding. But I think it's interesting to think about how we reconcile this. So what I'd like to say is that the ethics of clinical research really requires recognizing that there are 2 parts to this puzzle. That generating useful knowledge is an ethical responsibility, and that knowledge can promote benefits to society and to future patients. And that effort of generating useful knowledge for future patients and for society has to be constrained by, or balanced by, if you prefer the analogy, protecting and respecting the rights and welfare of the people who are participating and participants. And so there's this constant tension between these 2, and that's how we think about the ethics of clinical research. Interestingly, over time, over the history of clinical research, there's been interesting changes in how we think about this tension. So for many years, for hundreds of years, there were very few rules. Physicians, mostly physicians, experimented for 2 reasons. One, because they were curious and they had the luxury or the resources to be able to do so. And 2, because they wanted to benefit individuals. They found individuals that they didn't know what to do about in terms of their illnesses, and so they would experiment on them to try to figure out, well, does this work or does it not work? But there were no rules. We went through what people have referred to as a utilitarian era in the United States, maybe in other parts of the world as well, where the emphasis was on benefit to society. And many of the participants in research during that era were people who are now recognized as vulnerable. They were captive populations, people in prisons, people in institutions for the mentally ill, in orphanages, people who were seen as not only captive, but in some respects sort of marginal to society. And they made them useful by including them in research. Does it sound good? Can you guys hear me okay? Okay. That led in the late 60s, early 70s to a period of time where there was some pretty deep scrutiny of the scope and limitations of research. So a study that you might be familiar with that sort of led to this level of scrutiny, the Tuskegee syphilis study, where all of a sudden people realized, for 40 years we've been studying the natural history of a disease that had a treatment available to it, and the people in the study were not getting that treatment. Led to a series of congressional hearings, led to an act of Congress called the National Research Act, the creation of a commission, the National Commission for the Protection of Human Subjects of Behavioral and Biomedical Research, and then some rules. And the rules and regulations that we currently operate under were created at that time. They started at that time. And prior to that, there were very few rules about how we did research. There were very few laws or regulations that had much authority. The rules and regulations that were put into place starting around the 70s really had the focus and the emphasis of protecting human subjects, providing lots of procedural rules and other rules that would lead to the protection of human subjects from undue risk, as was already pointed out, from exploitation, and would respect their rights through the process of informed consent. In the last probably 20 years or so, there has been increased recognition of the possibility of benefit through participation in research. And this is benefit not just for the individuals, sometimes the individuals participate, but benefit for populations. So a recognition, for example, that doing research with children sometimes is really important so that we don't end up with therapeutic orphans, children who we don't know how to treat appropriately for certain diseases. Whereas if we don't include them for research, we're in clinical practice, we're making guesses about how to treat children. So having children participate in research is a benefit to children at large. International research has been seen in some cases as beneficial. And there's lots of ways that research has been seen as not just something to be protected against, but beneficial in some ways. During the same period of history, and this is a lot of history is very short amount of time, I can answer questions if you want more details, but during the same stretch of history, there are lots of important codes and guidelines that were written and are still have some power. And I suspect that many of these are familiar to you. The Nuremberg Code was the code that was written as part of the Nuremberg trials for Nazi war crimes, and it still has some influence in terms of how we do research in the world, not just in the United States. It's a very succinct code of 10 principles. The Declaration of Helsinki, which came along about 15 years later, was written by the World Medical Association, which is a sort of group of the American Medical Association and its equivalents in different countries around the world, and they wrote a document called the Declaration of Helsinki, which was, some people say in a little bit of a way, a response to Nuremberg, but a response in the following sense, that it recognized that a lot of research was done by physicians with patients, whereas the Nuremberg Code was written as a result of research that was done with prisoners in the context of war. The Declaration of Helsinki is, as people describe it, a living document. It's been revised multiple times. This slide needs to be updated. It was most recently revised in 2013, and it has a lot of very important pieces to it and a lot of authority around the world, and I can talk about what those are if you want to know. The Belmont Report is a document that was written by the National Commission that I mentioned a few minutes ago, and it's a pretty short, pretty clear explication of the principles that underlie the conduct of clinical research, and I'm going to come back to that in a moment. If you haven't read that, I would say take time to do so. It's not very long. SIOMS and the WHO, SIOMS is the Council of International Organizations of Medical Sciences, and they, in collaboration with the World Health Organization, developed international guidelines which were designed to take the principles enunciated in the Declaration of Helsinki and apply them to the context of doing research in the developing world. And there are two published versions of those guidelines, 1993 and 2002, and just in the last few months, a revised version is online for people to comment on. And so if you're interested in international research in particular, it's worth looking at. One of the things that I really like about the SIOMS document is that, in addition to principles, which many of these have, it has long, not long, but clear, detailed explications of how they came up with that principle and what they mean by it. So it's very useful. And the ICH-CPT is a very influential document in the world. It's an international conference on harmonization of clinical practice, which originally came about through the regulatory agencies of the United States, the European Union, and Japan, who wanted to find a way to agree on or harmonize the rules under which clinical research could be done, so that if you did research in one of those jurisdictions and wanted to have it approved by any other jurisdiction, you had to start all over again, which is what a lot of countries do require. So ICH-CPT has now been adopted by a number of countries around the world, and it allows for this regulatory reciprocity that's escalating. But in terms of E6 is the part of the ICH-CPT that speaks specifically to ethics, and it does adopt most of the principles from the Declaration of Helsinki. So you can see lots of interaction with these documents. So the Belmont Report I mentioned is a document that was written by the National Commission and has three underlying principles for clinical research: respect for persons, beneficence, and justice. And in the Belmont Report, they take each of these and not only describe what they mean by it, but they also apply it to a specific aspect of doing clinical research. So probably such of those of you who have ever studied ethics, these are principles that are commonly discussed that don't just apply to clinical research. They apply to lots of things. But in the context of clinical research, the Commission applied respect for persons to the idea of informed consent. They applied beneficence to the idea of risk-benefit assessment and how you make those calculations, and justice to the idea of fairly selecting subjects so that there are fair outcomes as well. The other important thing I think that the Belmont Report did is it describes the distinction between clinical research and clinical practice. And this is useful for thinking about the ethics of clinical research to sort of make these kinds of distinctions. So one thing that I already alluded to is the goal. So the goal of clinical research is to generate useful knowledge. The goal of clinical care is not to do that. It's to benefit the person or persons in front of you, the persons that are being cared for in the practice. And you can see how sometimes those two goals can come into tension and need to be reconciled. Methods are also very different. So common methods in clinical research, we talk about double-blind trials, placebo-controlled trials, dose escalation trials. The kinds of things that we do all the time in research are very foreign concepts in clinical practice. So it would be very weird for you to go to your doctor with a sore throat and have the doctor say to you, I'm going to give you one of two drugs, but neither you nor I are going to know what the drug is to heal your sore throat. And yet research reaches that all the time. The other important difference from an ethical perspective is the justification for risk. So it's clearly not the case that in clinical practice there are no risks involved. There are certainly risks in taking medications and having surgeries and interventions, etc. But all of those risks are justified by the potential for the benefit that intervention offers to the individual who's undergoing it. Whereas in research, we often ask people to do certain things, procedures or interventions, that have no corresponding benefit to them, but they're being done to answer a question. So we might ask for an extra biopsy, an extra blood draw, an extra scan, a pharmacokinetic test, something like that that exposes people to certain risks for the purpose of answering an important scientific question, but not for their benefit. And so there's three ways that research and clinical research and clinical practice are distinguished, and they're very important to keep in mind because they help us answer a lot of questions about what's acceptable and what's not. And the Belmont report begins to describe those differences. In addition to codes and guidelines, there are regulations. Okay, so in the United States, there are two important sets of regulations that are worth knowing about. One is the common rule. How many of you know about the common rule? A couple people. Okay, the common rule is US 45 CFR 46. Also, walking around the halls of this building, sometimes you hear people just talk about it like that. They don't call it the common rule, they call 45 CFR 46. And so the 45 CFR 46 is Title 45 of the Code of Federal Regulations, Part 46, and it is the Department of Health and Human Services version of the common rule, the regulations for protection of human subjects that anyone getting Department of Health and Human Services money has to follow. The reason it's called the common rule is that there are 16 other federal agencies that also follow the same set of regulations. Their regulations are found in different parts of the CFR, not all in Title 45, that's the HHS, but the content of the rule and the regulations is similar across 16 other federal agencies in the United States. One of the agencies that does not follow the common rule is FDA. And FDA has its own set of regulations. The regulations that are found at Title 21 of the CFR and at Parts 50 and 56 are very similar to what's in the common rule, have a lot of the same requirements, but some important differences. And then there are other parts of the FDA regulations that are very important for somebody who's doing a treatment IND, for example, or a device trial. And then there are policies and guidelines that the NIH requires. So, for example, how many of you are investigators? Couple. Okay. So if you're how many of you are IRB members? Anybody? No. Okay. There are some requirements for inclusion of women and ethnic minorities and children in research that are NIH requirements, but that are requirements, I guess is the way to say it. And there's some others that the NIH has that are NIH policy that applies to clinical research. So what does 45 CFR 46 include? There are really three things that are, there's a lot more than this. There's federal regulations are, I don't know how many pages, 15 pages or something of detail. And so if you are on an IRB or if you're getting ready to write a study, you might really want to know about what the details are. But basically, they cover three broad areas. One is a lot of description about the composition and function of local institutional review boards or IRBs. Another is the criteria that IRBs should use when deciding whether or not a study is approvable. And the third is requirements regarding informed consent of individuals that are going to be included in the study. So these are spelled out in the common rule and also 45 CFR 46. 45 CFR 46 also has subparts that pertain to additional protections for groups of people that are considered vulnerable for a variety of reasons. The subpart D refers to fetuses, pregnant women, and human indeed for fertilization, treated prisoners, and deeds of children. And there are some very specific additional requirements that research with these populations entails. The FDA regs, I already mentioned that the 21 CFR 50 and 56 are very similar to what's found in the common rule. The Part 50 is about informed consent. Part 56 is about IRB composition and function. There is also a subpart D in the FDA regs that deals with extra protections for research for children. And then there are IND and IDE regulations found in 312 and 812 that are very important to your investigator who's testing a new investigational new drug or device. So that's a whirlwind through a little bit of history and a little bit of the rules and regulations that exist. What I want to spend the rest of the time talking with you about are some sort of conceptual ideas about how you think about research in a way that helps you answer the questions of, is this research ethical? And I want to preface it by saying that, in our department some 15 or so years ago now, we realized that a lot of the guidance that's found in the codes and the regulations were developed in response to specific problems. They were developed historically at a time that they were responding to some events that happened in history. And so they understandably kind of focus on what the sort of details of that event that initiated their implementation. In addition to, or because for the same reason perhaps, some issues are probably incompletely addressed in some of these guidances, and some of the guidances and regulations are at least interpreted to have divergent recommendations and not agree on specific things. So we thought that there was a need for investigators, for people who are interested in understanding the ethics of research, for people who review research, IRB members and others, to have a systematic, coherent, and universally applicable framework that they could use to make decisions about, or make judgments about whether or not a particular research that they were writing or reviewing was ethical. And so we proposed a 7-principle framework. The 7 principles, and published in a couple of different places. The first paper was in 2000 in JAMA. It's also in a textbook. There's some additions to this in the international context. There's a number of references that I can provide for you if you want that explicate that this pretty in some detail. But I'm going to go through it today. So the 7 principles include valuable scientific question, balanced scientific methodology, fair subject selection, favorable risk-benefit evaluation, independent review, informed consent, and respect for moral purpose. One thing before I go into each one of them I want to say is we didn't make any of these up. So if you look at the various guidelines and codes, you will find vestiges of each of these, maybe not exact words, but the concepts and the ideas are there. We just put them together in a way that seems more systematic to us. And what I mean by that is that it seems right that you have to start at the top. You have to answer the question, is this a valuable scientific question, before you go down the list. And so, the question of informed consent is on there. It's a very important part of doing research, but you don't even get near it until you've gone through lots of other considerations in terms of a concept. So what do we need to have about a valuable scientific question? So basically what this means is that it has to be worth doing, if that's the shorthand for it. An ethical clinical research should answer a valuable question, one that will generate new knowledge or understanding about human health or illness that's socially, clinically, or scientifically useful. So a good example of this is an article that was written by a very prolific writer in research ethics, Benjamin Friedman, who wrote an article about, in his article he was writing about social value in a certain way. And what he said was he had a nightmare. He was walking down the hall, and he ran into one of his colleagues who excitedly came to him and said, I just successfully transplanted an appendix. And in the article, Benji says he kind of scratched his head and he said, well, was that ethical? And his colleague responded, well, I got the guy's informed consent. And he uses that as an example of how informed consent doesn't solve the problem. If there wasn't a good reason, a good question to answer by transplanting an appendix, something that you might learn, something that you might use to do some important work with, then it wasn't ethical to do it. And it's an interesting concept because it seems like it is the most important first question to ask. Is this research worth doing? Now, importantly, it doesn't mean that the answer to the question has to be positive. You can have negative, ask the question and get negative answers, and that's still socially valuable. It still gives you information that can be very useful, and in many cases it is. But if you can't answer, if you can't say why this question is worth asking, then you probably have to re-ask yourself if this research is ethical. There are many reasons that social value is important. It promotes benefit to society, so there's the sort of one side of the balance that I showed you before, and it also minimizes exploitation. You're asking people to do things for a good reason, not just wasting their time for nothing. Therefore, it justifies asking them to accept some risk and burden, and it's also a responsible way to use resources. The second principle in the framework is scientific methodology. And this basically says ethical research should be designed in a methodologically rigorous manner. The design, the methods, the statistical power, etc., that will yield valid, reliable, generalizable, and interpretable data. So the shorthand here is, if a question is worth asking, the second ethical requirement is to design it in a way that you get an answer that you can interpret, that you know what you found, that you have data that's reasonably understandable. Again, it doesn't have to be positive, it just has to be understandable. And it has to be designed in a way that's feasible as well. Now, this requires lots of details in terms of choices of endpoints, choices of designs, choices of procedures, statistical methods, etc. And you look at this list, and some of you might say, well, those are all scientific considerations. And in fact, they are scientific considerations, but every scientific choice that you make has ethical implications. And so designing your study, picking the right outcomes, picking the right design to give you the best, most rigorous answer to your question, choosing the procedures that will be used to measure outcomes or data points or whatever, and not only planning your statistical methods for managing your data.
これこれは
リモコンないんですよ。
はい。
で、これも発電性より
あります。
これも発電性。
わかりました。ありがとうございます。はい。
In terms of scientific objectives. Scientific objectives is where you start, and then when you're thinking about fair subject selection, there's also a consideration of fairly distributing the harms and benefits. So let me give you an example. Let's imagine you think you're doing a study to test a treatment for breast cancer. And scientifically, you're going to need people in that study who have breast cancer, and maybe a very specific type of breast cancer. When you're thinking about fairly distributing the harms and the benefits, you may think about, well, which subgroups within the population of people who have breast cancer are more susceptible to the kinds of risks that this intervention might have. Maybe kidney disease or liver disease or some kinds of things that might need to be used as exclusion criteria in order to reduce the risks and protect some of the subgroups. One of my colleagues talks about the best way to think about fair subject selection is to flip it on its head. In other words, not start with who scientifically should you include in the study, but start with the idea that everybody should be included unless there's a reason to exclude them, a justification for excluding them. And so then the question becomes, what are acceptable justifications for excluding people? Well, one might be that they can't help answer the question, they don't meet the scientific objectives. Another might be that they are at higher risk than everybody else who could meet the scientific objectives. And a third, and a very important one, is that they may be more vulnerable than other populations, and therefore we should think about whether we need to include them at the front end. I understand there will be another lecture, a whole lecture on vulnerability, so I won't say more about that, but if you have questions, we can talk about that. I think it's important to go back to something I've already alluded to, and that is, in thinking about distributing or fair distribution of risk and benefits, it's important to keep in mind this sort of pendulum swing that's been occurring between thinking of research as always a burden and as always a need of protection, and the sort of opposite swing of the pendulum where research can be or is, in many cases, benefit, and subjects need and want access to participation. And so thinking about the risks and benefits, we need to keep in mind those different poles and where any particular project might fall in that spectrum. So you've got a question worth asking, a design that's rigorous, selected the appropriate population given scientific objectives and risk and benefit and vulnerability. And now the question is, what's the risk benefit look like for the participants in the study? So this is a sort of different kind of risk benefit analysis than the first one, which is this study worth doing. In a study that's worth doing, there are still ways that one can make sure that the risks to the individuals in the study are minimized and necessary. So you may see a proposal, for example, that asks to do 10 MRIs over the course of 6 months. And so an interesting question to ask is, are 10 necessary? Or could the question be answered by doing 6 or 5 or spreading them out over a further amount of time? Are there other ways to minimize the burden of those procedures to the participants? Are the risks to the individuals in the study justified by either benefit to them or potential benefit to them, or the importance of the knowledge for social value? And are benefits enhanced? Are there ways to enhance benefits in the process of doing research? And these are, you might say, well, these are pretty normal, understandable questions, no big deal, but the process of doing it is not so straightforward. And just thinking about risk, for example, there's a very interesting challenge in terms of defining what is a risk in research. What counts as a research risk? How do we know how bad this risk is, or how to think about this risk on some kind of scale? And there are certainly lots of reasons to think about both probability and magnitude of risk and different types of risk. So one of the things that the regulations talk about is physical, psychological, social, financial risk. It's interesting to think about how often in research we consider financial risk as an example. Some people talk about, or I've had questions raised that fall in the following sort of category. If somebody has to travel through a very tough neighborhood or park really far away from the clinic and walk to the clinic and there's some hazards in that walk, are those risks of research or are those separate from the risks of research? How do we take those things into account when we're making an assessment of what the risks are? And I think importantly, in all cases of research, there is some uncertainty about risk. And if there wasn't some uncertainty about risk, we probably wouldn't be doing the research, because part of doing research is helping to identify either what the risks are, the magnitude of the risks, the comparative risks, or some other nuance about the risks. So defining risk and measuring risk is a very important part of figuring this out, but it's not easy in many cases. Minimizing risk is also something that we need to pay attention to, and some things are very straightforward. I mentioned already, reducing the number of procedures if you can and still get an answer. Other things that people talk about are, doing procedures that are clinically required, and in other words, instead of asking for additional blood for research purposes, have it drawn at the time when clinical bloods are being drawn. Making sure that the people who are doing procedures have the right kind of training, that's a way to minimize risk. So there are lots of really important, sometimes very obvious ways to minimize risk. And limiting risk really gets down to how we protect certain groups of people. So one of the ways, for example, that the regulations regarding research with children work is that it limits the amount of risk that children can be exposed to in research. Minimal risk procedures in research for children are generally fine. More risk can be accepted when there's a prospect of benefit for the children in the study, and then the rules for anything more than a minimal risk without a prospect of benefit in children are much more stringent, and in some cases research cannot be done. There's also similar challenges in terms of defining benefits. What is a prospect of benefit in research? If you have a certain kind of serious illness, and there are a few interventions available to treat that illness, and you are entering a study in which there's an intervention being offered, is that by definition a prospect of benefit? Is it only a prospect of benefit if we already know something about the drug? If it's in phase 3 versus phase 1, for example? How do we decide what's a prospect of benefit in certain cases? And a lot of discussion about distinguishing what are called direct benefits versus secondary or sometimes ancillary benefits. So the direct benefits are, maybe the possible therapeutic benefits that one might derive from an intervention. The secondary benefits might be other medical care that you might receive as part of the study, payment that you might receive as part of the study, feeling like you're contributing to society that might be psychologically beneficial as part of the study. Those are generally considered those secondary benefits. So importantly, going back to my original balancing scale, most guidance recognizes that interests other than the subject, those are the subjects, may on some occasions be sufficient by themselves to justify risk. What this basically means is that research in which we know in advance the individuals who are participating will not benefit, there's no prospect of benefit, can sometimes be ethically acceptable as long as the rights of the individuals who are participants have been adequately protected. So, a question worth asking, a design that's rigorous, the right population chosen, efforts made to minimize risk and enhance benefits. Now, the next thing on that list is independent review. And so this is a process which allows an investigator or a research team who has investments in research to have somebody else say, is this successful? To ensure that the other requirements have been filled, check any biases that the investigator might bring, and assure the public that research is not exploiting individuals or groups. And so most research in the United States is independent review by institutional review boards, or IRBs. There is research that's exempt from IRB review and expedited through IRB review, so there are other methods of reviewing. Most countries around the world have an equivalent kind of ethics research review committee that does look at research before it starts, research with humans. And the criteria that are found in both the Common Rule and in the FDA regulations that the IRB is supposed to use in order to determine whether a particular study is approvable include these, and you'll see flavors of things that I've already talked about. That risks are minimized, there's more to that statement than I put on the slide. The risks are justified by any anticipated benefits to the subject or the importance of the knowledge. The subject will be selected and treated fairly, and that informed consent is adequate. There are lots of interesting and in the news challenges right now with IRB review. One is, many IRBs have huge volume of protocols to review. So how many of you have ever been to IRB? Anybody? Only one. Okay, two. Okay. So oftentimes an IRB meeting can last 4 hours, but you have, maybe 10 protocols to review. Some of them, protocols sometimes are, 300 pages long, and dense in terms of their scientific background, etc. So the challenge is not trivial in terms of understanding what it's about, having the process of asking questions often of the investigator, and then applying these principles and thinking about, well, is this something that's approvable in its current form or does it need to be changed? Consequently, there's been plenty of evidence to show that IRBs tend to be inconsistent in terms of how they make their judgments. And this has created problems in particular for multi-center studies or multi-site studies. So if you have a study that has 100 different sites, oftentimes 100 different IRBs have to review it, and they may have either grossly different decisions or sometimes just mildly different decisions, but that impact the entire spectrum of sites that are conducting the study. So this is a problem that a lot of people have talked about, and lots of attention right now to using single IRB review for multi-site studies. This year, in September of 2016, the Department of Health and Human Services published what's called the Notice of Proposed Rulemaking. That's what NPRM stands for. Maybe some of you have heard about it. And basically, it's a proposal for changing the Common Rule. And there's some very interesting, some minor and some huge changes in terms of what they're proposing. One of them is this, that for multi-center studies that are domestic, non-international, a single IRB review will be required. They won't be able to have different institutions doing IRBs. That's reviewing different institutions that are reviewing the study, but only one will be able to do it. And there's a lot of consternation about how this is going to look and whether it will work and whether it will be adequately protective and how you make arrangements between institutions and lots of details. So the sixth of the seven on our list is informed consent. And as someone in the audience said, a lot of people, when they think about, sort of abstractly, what is it that makes research ethical, clinical research ethical? The answer often is informed consent. And certainly in most cases, informed consent is an important part of doing ethical research. But what's interesting about it is, if you think about it, until you have a proposal that's worth doing and well designed and you've minimized risk and have somebody else review it, there is no reason to ask anybody for their informed consent. You don't even get there until you've gone through those other steps. But informed consent, once you're there, has a goal of making sure that the people that you're offering participation to have an opportunity to decide whether they want to participate or continue to participate and whether or not participating is compatible with their goals and their interests and their values. So it's a really important concept. Most of the documents that code